from Memorial Sloan-Kettering Cancer Center to share more with us on this topic. Welcome, Dr. Queliza. Thanks so much for being here.
Of course. Let me share my screen. Is my presentation showing appropriately, or?
Yes, we can see it.
Okay, all right. Hi, everyone. Thanks for having me. My name is Dr. Queliza, and like Jordan said, I'm from Memorial Sloan-Kettering in New York. Today, I will be talking about gastrointestinal issues in children with Fanconi anemia. Okay, so topics that I will discuss are abnormalities of the GI tract, issues with nutrition that can be seen, including poor growth and obesity, liver disease, and GI and liver complications after hematopoietic stem cell transplant. I will also talk a little about what we do and do not know about GI-related cancer screening, as this is still a topic that needs further investigation among our Fanconi anemia patients. I want to start off with the basics, explaining what makes up the digestive system, which is responsible for digesting and breaking down food, as well as absorbing nutrients. So here on the right, the gastrointestinal tract, or GI tract, is a winding tube that begins at the mouth and ends at the anus. It includes the esophagus, which you may have heard as referred to as the swallowing tube or food pipe, which then goes into the stomach, small intestine, and finally the large intestine. On the left side are the accessory organs, which are the organs that are not necessarily part of the GI tract or the long tube, but they are still important in digestion, and they include liver, gallbladder, and pancreas. There are several symptoms that one can have that can help us identify whether or not there's an issue related to the digestive tract. And examples include nausea, vomiting, difficulty with swallowing, decreased appetite, abdominal pain, and diarrhea. So obtaining more information about the details of these symptoms can be very helpful. For instance, how long have these symptoms been occurring? Do the nausea, vomiting, or abdominal pain occur more frequently at a certain time of the day? Are there associated symptoms such as headaches? Have you noticed certain triggers, such as performing a certain activity like running around or eating specific foods? Does anything make the symptoms better, such as taking an over-the-counter medication, such as ibuprofen or Tylenol? If the patient has diarrhea, have you seen blood mix in the stool? Is the diarrhea worse in times of stress or anxiety? These are all details that could be helpful for us in determining the underlying cause and how best to manage the symptoms. So let us now talk about anatomical or structural problems that patients with Fanconi anemia can be born with. Approximately 7% of patients with Fanconi anemia are born with some sort of structural abnormality in the GI tract. And these abnormalities are often diagnosed even before Fanconi anemia is diagnosed, since patients can present early on after birth with feeding issues. The most common GI tract abnormalities among Fanconi anemia patients include esophageal atresia with tracheoesophageal fistula, duodenal atresia, and anorectal malformations, which I'll get into in a bit. So other abnormalities that have been reported in our patients include those related to the pancreas, those related to the bile ducts that are outside and inside the liver, which you may have heard as biliary atresia. And also you could have twisting of the intestine, such as intestinal malrotation. And then among other GI issues, you could have birth defects related to other organs, such as the heart or kidneys, or maybe abnormalities in your extremities, such as your arms or legs. So looking at the left diagram, you can see that the GI tract starts at the mouth, followed by the esophagus or the swallowing tube or food pipe, then the stomach, and then the small intestine. So a patient with esophageal atresia is a birth defect where there is no continuous connection between the esophagus and the stomach. I'm not sure if you see my arrow. In other words, the lower end of the esophagus can be incomplete. There can be some sort of ending here, and so food and liquids cannot freely pass from the esophagus into the stomach. Patients also can have an abnormal connection between the esophagus and the trachea, or your windpipe, which is part of your airway system. This is called a tracheoesophageal fistula. Fistula just meaning that there is an abnormal connection. Duodenal is another birth defect where the first part of the small intestine, seen here after the stomach, called the duodenum, is incomplete or blocked. Again, food and liquids cannot pass through the rest of the intestine to travel further down the digestive tract. This diagram is showing the small intestine in the back, followed by the colon or large intestine. So Fanconi anemia patients can have anorectal malformations. And so that's specifically this area here, which is part of the colon. So the rectum is the last part of your colon, and the anus is where the bowel movements exit. So patients with any abnormalities here, they could have either a blockage of the anus itself. You can have a lack of connection between the rectum and the anus, or you can even have a connection between the rectum and another part of the body, such as the bladder or another part of the urinary tract. So as I mentioned previously, most GI tract abnormalities are diagnosed and treated early in infancy, so patients will often present with feeding problems. Surgery would then depend on the location of the abnormality. Patients can sometimes experience complications related to the site of the repair. So where they could develop strictures or narrowing. For instance, in a patient who had esophageal atresia that was repaired, they may develop a narrowing at the site somewhere in the esophagus, and the patient can have issues with coughing, choking on food, vomiting, or just refusing to eat. So in some cases, dilation or stretching of the stricture might then be helpful. Patients can also have issues with gastroesophageal reflux disease, which I will get into more detail soon. Difficulty swallowing, slow movement of food through the digestive tract, also known as issues with the motility of the GI tract, and as well as constipation and stool accidents. So touching more on issues with narrowing, so dilation or stretching of these strictures can be performed with endoscopy, and that can be either performed by the patient's initial surgeon or usually a gastroenterologist. So here in this picture, you see a black tube, which is our endoscope. It's a narrow, bendable tube that has a camera and a light at the end of it. The endoscope allows us to look directly into the GI tract. And we can sometimes, depending on the need, we can also take pieces of tissue so that we can review under the microscope. And these biopsies are very small. They're around the size of a pinhead. So in patients with esophageal stricture or narrowing in the esophagus, we can use a balloon like in the upper right corner to slowly stretch out the stricture. And during the procedure, we do sometimes need to use a portable X-ray machine while dilating. And as for all patients, but also keeping in mind that Fanconi anemia patients have sensitivity to radiation exposure, we adjust the machine settings and the location of the X-ray machine to ensure that we are using the lowest amount of radiation that we need to perform the procedure effectively and safely. So this view that you see here is from the endoscope looking at a stricture in the esophagus of a toddler that I have treated in the past. You can see that the hole is rather small, and you can imagine that the patient was having issues with swallowing any foods and liquids. So since dilation takes several sessions to gradually widen the opening, this patient did have a gastrostomy tube or a feeding tube directly in the stomach to ensure that he could receive adequate nutrition while we treated his stricture. This is an X-ray picture taken during one of his procedures. Here, this is the tube, this is the endoscope, and this other elongated figure here is the balloon. And you can see that the balloon is filled with contrast, and the X-ray can help us to confirm that we are in the right position in relation to where the stricture is. And finally, this picture on the right is of the esophagus after several dilation sessions. And you can see that the opening is rather nice and round and able to have food pass freely without getting caught. Let's now talk about gastroesophageal reflux disease. So first, for some definitions, gastroesophageal reflux is the flow of stomach contents going back into the stomach. This is a normal physiologic occurrence that can happen in healthy infants, children, and adults, and it may not It may or may not include vomiting or some spit up of a little fluid. And most episodes of reflux are brief and do not cause symptoms. Gastroesophageal reflux disease, or GERD, which you may have heard of it be referred to, is when patients have troublesome symptoms related to the reflux and or they have complications. So complications include recurrent lung infections, inflammation of the esophagus, and poor weight gain or weight loss. So patients with esophageal atresia and other GI tract abnormalities are at risk for having reflux disease. And other patients that also are at risk include patients that have been born prematurely, patients with underlying lung diseases, or if they have any developmental or neuromuscular disorders. So regarding signs and symptoms, younger patients who cannot express where their pain is may actually just show that they're irritable, they may not eat as much. Other patients that can communicate and tell us where they're having pain, they can refer to chest pain, they can have vomiting, and sometimes you could have a patient that has non-GI related symptoms such as cough, hoarse voice, breathing issues, recurrent issues with their asthma, some lung infections, and even dental issues. So in Fanconi anemia patients, we manage gastroesophageal reflux disease by treating the inflammation and irritation of the esophagus. And we do this by giving medications that lower the amount of acid in the stomach. Just to keep in mind, these medications do not prevent the reflux itself from occurring, but instead they help the stomach contents to become less irritating when they do come into the esophagus. So this first type of medication, the proton pump inhibitors, they work by lowering the production of acid in the stomach. And they include lansoprazole, omeprazole, and esomeprazole. And you may have heard of them from their brand names, such as Prevacid, Prilosec, and Nexium. These are available over the counter, so you may have also seen them there. Histamine 2 receptor blockers are another group of medications that can lower the amount of acid made in the stomach. In general, these are avoided in patients with Fanconi anemia. There is a study that had shown that among bone marrow transplant patients, they found that ranitidine or Zantac was a possible cause of suppression of the bone marrow in a small amount of patients. So while more research is needed on this topic, some people do recommend that we avoid this type of medication in Fanconi anemia patients, as well as bone marrow transplant patients. Anti-reflux surgery, or Nissen fundoplication. It is a surgery that reinforces the muscles between the low end of the esophagus and where it meets the stomach, and it can help prevent contents from coming up. Now, we only perform these surgeries when patients are still having severe symptoms despite being on medication, and there are also life-threatening complications, such as they're not gaining weight appropriately, they're having breathing issues, they're having multiple lung infections. These are all reasons why we would consider doing the surgery. Gastroparesis is another issue that to think about if a patient has GI symptoms. It is an issue with the motility or movement of the stomach, and in general it involves where contents of the stomach take longer than usual to empty. So patients can feel nauseous, they can feel full after eating a very small amount of food, and they can have delayed vomiting, so vomiting 30 minutes or an hour after eating. Many children with delayed emptying of the stomach have no actual cause of the disorder, but there are some patients that have reported having had a recent viral illness that they recovered from. Other causes can include certain medications, such as opioid medications for pain. Certain antidepressants can do this as well. Also, if the patient had a recent surgery or has an underlying neurologic issue as well, these can all impact how food and liquids flow in the GI tract. So how do we come to the diagnosis? So the diagnosis can be made by performing a gastric emptying scan. This is a nuclear medicine study where we measure the amount of contents left in the stomach immediately after a meal, as well as 1, 2, and 4 hours later. And in general, if 4 hours after eating, if the amount left in the stomach is more than 10% of what was originally seen, then that is suggestive of gastroparesis or poor emptying of the stomach. Since there is radiation risk with gastric emptying scans, though small, it is reasonable to perform a medication trial and see if there is improvement in symptoms after starting the medication. So medications that promotes the pumping of the stomach and kind of the motility of the stomach include erythromycin, metoclopramide, and amoxicillin clavulanic acid. Oftentimes, patients benefit from also having anti-nausea medications on board because the motility agent itself can sometimes cause nausea. Not listed here is ciproheptadine, which you may or may not have heard of in the past related to appetite stimulation. It's not necessarily a motility agent, but it can help for gastric accommodation, meaning it can help the stomach relax and accept food when it is swallowed. So some patients do benefit from that as well. Some dietary changes that can be helpful for gastroparesis include eating small meals that are low in fats and non-digestible fibers. So non-digestible fibers are like wheat, grain, and whole grain foods. And eating small portion sizes frequently throughout the day can be helpful. So working with your dietitian to help adjust meal plans and figure out what is reasonable based off of the patient's preference, that would be helpful for management of gastroparesis. Small intestinal bacterial overgrowth is another disease process that should be considered in a patient with GI complaints. It refers to excessive growth of bacteria in the small intestine. So risk factors include prior GI surgery or resection, abnormal anatomy in the presence of strictures, impaired motility, meaning again, issues with movements of contents through the GI tract. Certain medications can put someone at risk for this, especially acid suppression, which, as we discussed earlier for reflux disease. And that is because stomach acid normally prevents growth of bacteria. So when we're suppressing that, you can also sometimes have growth of other bacteria in your intestines. Other medications to consider are antibiotics and opioid medications. And then certain inflammatory disorders, such as inflammatory bowel disease and other autoimmune processes, they can also put someone at risk for developing this bacterial overgrowth in the small intestine. So signs and symptoms of small intestinal bacterial overgrowth can vary. So patients can actually have no symptoms at all, or they can have bloating, excess burping, or passing gas from below, nausea, pain, diarrhea, or constipation, oily stools, weight loss. You can have anemia, and certain vitamin deficiencies you can see, such as deficiencies in vitamins A, D, or E. So the diagnosis can be made by performing a breath test, a hydrogen breath test. So essentially the patient ingests some sort of carbohydrate, such as glucose or lactulose, and the patient's breath is then analyzed several times over the course of a few hours. And that is because if a patient has bacterial overgrowth, the bacteria will break down the carbohydrate that was ingested and produce hydrogen in the breath. So that's why we test the breath. A more definitive diagnosis can be testing fluid from the small intestine. However, that is more invasive in the sense that we need to do that endoscopically. It's actually hard to accurately perform. So this is not a typical diagnostic method that we use. If there is a high concern for small intestinal bacterial overgrowth, patients can alternatively just be trialed on therapy instead of undergoing a hydrogen breath test. And specific antibiotics for treatment include metronidazole and rifaximin. It's also important to try to treat the underlying cause if identified. Some patients ask about prebiotics and probiotics. Prebiotics are a type of fiber that can help grow certain bacteria, while probiotics are you're actually giving bacteria, such as what you see in what is present in like yogurt. There's not enough data right now in children for the use of these for intestinal bacterial overgrowth, but it's definitely something that is being considered. If there is lack of response to initial therapy, it can be helpful sometimes to try a certain diet, such as what you may have heard of before, a low FODMAP diet or drinking elemental formula. And I won't go into the details of the diet, but in general, the goal is to increase nutrients that can be absorbed easily by the gut. So there's less nutrients that are available for the bacteria to break down and use for them themselves to grow. So those are things that we consider. Next, I want to talk about nutrition issues in children with Fanconi anemia. About 60% of children have short stature related to the underlying genetic disease and have proportionately lower weights. So because of the short stature, it is important to look at proportions of height and weight rather than the height and weight individually when trying to assess a patient's overall nutrition status. One study had reported that 22% of Fanconi anemia patients had low weight with respect to their height. So when we're considering treatment options of how to address this, it is also important to consider what else could be contributing also with their growth. So hormonal abnormalities are possible, since 80% of Fanconi anemia patients have at least one endocrine abnormality, such as short stature, growth hormone deficiency, low thyroid hormone. We also need to keep in mind the heights of the parents and the possibility of an ongoing infection that could lead to inflammation and then have effects on growth as well. So in general, evaluation should include a good history of symptoms and physical exam, obviously. Certain labs and stool studies might be sent depending on the symptoms that are described. Again, looking at the proportion of height and weight is important. Height and weight should be measured at each clinical visit and plotted on the growth curves. So when looking at proportions, we use the weight for length chart for patients less than 2 years old and the BMI for age for patients greater than or equal to 2 years old. If patients are not growing and or gaining appropriate weight, they may need supplemental feeds, medications to increase appetite, as well as involvement of the nutrition and endocrinology teams. So this leads into the topic of enteral nutrition. Enteral meaning some sort of nutrition that's passing through the intestines. Enteral nutrition is preferred in general over parenteral nutrition, and again, parenteral meaning a route that is not via the GI tract. So that here we're talking about injection through a vein, as it is for total parenteral nutrition, or TPN, which you may have had experience with. So enteral nutrition is superior to parenteral since it's physiologic, meaning that it reflects the natural way of how food should be digested. It stimulates the GI tract and encourages the GI tract to maintain its function. And there's also a lower risk for infection. We think about starting enteral nutrition supplementation in patients who are unable to tolerate enough by mouth, particularly less than 80% of their caloric needs, and also if they have poor weight gain. So this can happen if a patient has poor appetite, problems with swallowing, or some patients just need more energy and more calories than what they are already consuming because of their underlying illness. So here, a feeding tube is placed if a patient, again, is unable to eat enough or drink enough supplemental formula by mouth to gain weight appropriately. So tubes inserted through the nose are meant to be temporary. At most, they're kept in place for 6 to 8 weeks at a time with the thought that the patient would be able to resume consuming all of his or her needs by mouth. Patients most commonly will have a nasogastric tube or an NG tube, which passes through the nose and ends in the stomach. If the patient has delayed emptying of the stomach, tubes will sometimes be placed further down in the GI tract, like what you've may have heard of before as ND or NJ tubes, so nasoduodenal or nasojejunal tubes. Another reason why tubes might be placed further down is if the patient has really bad reflux disease or if the patient has a high risk of aspirating fluid. So if we're concerned that the patient has bad reflux, these contents, even though going to the stomach, they could still come up and go potentially into the lungs. A gastrostomy tube is a tube that is placed directly into the stomach, and a G-tube is placed when a patient is expected to need formula feeds for a longer period of time, so months to years. And similar to the patient that I mentioned previously requiring the dilations, patients that have esophageal atresia or severe strictures or injury, they may need a G-tube placed earlier on, so we can help treat the stricture first and the patient can still have ongoing nutrition. So if a patient has a tube that ends in the stomach, whether it is an NG or a G tube, there are two options that the formula can be administered. They can be given bolus and continuous. And you may have touched on this already in one of the nutrition talks. So bolus feeds involve giving a certain volume of formula in less than 30 minutes every few hours. And this mimics meals and is more physiologic. They allow for freedom of movement between feeding since the patient does not have to remain connected to a pump. But some patients do have issues with this and may have diarrhea. Continuous feeds involve a slow infusion of formula, and this can be given overnight to avoid any disruption of daytime schedule or oral intake. And of course, you could have a combination of both. You can have bolus feeds during the day and then continuous at night. At the other end of the spectrum, one study reported that 27% of FA patients were overweight or obese. And this can lead to abnormal cholesterol levels, liver disease, development of diabetes, obstructive sleep apnea, and cardiovascular disease. Primary management involves making healthy lifestyle changes. So for diet, it's important to eat 5 or more servings of fruits and vegetables per day. You want to avoid sugar-sweetened beverages such as juice, Kool-Aid, or sports drinks like Gatorade. It's also important for the family to make dietary changes since the house needs to be stocked with healthy food choices. And I often recommend trying to have family meals together at the kitchen table so that patients are less likely to eat extra snacks elsewhere if there's a more regimented scheduled time for eating. Obviously, exercise is important. You want to have some sort of aerobic exercise 3 to 5 times per week for at least 30 to 60 minutes at a time. And also decreasing screen time. So 2 hours or less of some sort of screen time, such as using your phone, iPad, TV, computer, that would all increase the activity levels. So liver disease in Fanconi anemia patients is generally a complication of treatment. Some patients are prescribed androgen therapy for low blood counts or aplastic anemia. So examples of androgen therapy are danazol, oxymethylone. So signs and symptoms of liver disease include abnormalities in different liver enzyme tests. You could also see jaundice, which is yellowing of the skin or the white parts of the eye. And use of androgens can increase a patient's risk for developing liver tumors, such as adenoma or hepatocellular carcinoma. So the first one, hepatocellular adenoma, is benign. It's not cancerous, but it can rupture and lead to bleeding, especially if a patient has a low platelet count. And you can see this type of tumor develop within 3 months of beginning androgen therapy, but it can also go away after stopping androgen therapy. Hepatocellular carcinoma is a cancerous tumor. So these tumors can be diagnosed with imaging, so ultrasound, CT, or MRI. While on androgen therapy, it is recommended to follow liver enzymes every 3 to 6 months and do some sort of imaging, specifically liver ultrasound, every 6 to 12 months. If discovered, management can include discontinuation or reduction of the dose of the androgen therapy. Some tumors may need surgical resection or radiofrequency ablation, which is performed by radiology. Essentially, they use radio waves to create heat and destroy the tumor. But again, it all depends on what we see in the patient. Fanconi anemia patients can also develop iron overload from receiving frequent blood transfusions for aplastic anemia. So you can have some organ damage to the liver, pancreas, and heart. Patients can potentially develop an enlarged liver, or you may not have any signs or symptoms at all. Lab tests that can point toward the diagnosis include certain liver enzyme tests, as well as checking iron levels in the body. A specialized MRI study can measure the amount of iron that's deposited in the liver. Sometimes a liver biopsy is helpful to assess, again, the amount of iron that's present in the liver and to also look for any scarring or fibrosis of the liver. For management, this is typically performed after transplant. Some patients may require ongoing phlebotomy or removal of blood to take out the iron. There are also some drugs that can be prescribed, such as GvHD. It's a chelation therapy, meaning that these are drugs that bind the iron and remove it from the body. Moving on to graft versus host disease. This is a complication that can occur after hematopoietic stem cell transplant. It occurs when the transplanted cells or the graft recognize the patient's body or the host as foreign and then therefore attack the body. And this can arise in the GI tract, liver, and or skin. Fanconi anemia patients are at increased risk for developing graft versus host disease after transplant, and it's thought to be related to underlying issues with DNA repair. And the rate of chronic GvHD in patients with Fanconi anemia can be as high as 60%. So graft versus host disease can be classified as either acute or chronic based on the type of symptoms. And in general, Fanconi anemia patients with chronic GvHD, they have an increased risk for developing squamous cell carcinoma, particularly of the head or neck after stem cell transplant. So graft versus host disease can affect any part of the GI tract and have very non-specific symptoms, including mouth pain and ulcers, difficulty swallowing, chest pain, decreased appetite, feeling full easily, nausea, vomiting, abdominal pain, and diarrhea. Patients with chronic GvHD can develop strictures in the esophagus, or they may see that their stools are floating in the toilet, which suggests that there's fat in the stools, and that may signify an issue with the pancreas. For diagnosis, ultimately the diagnosis is reached by obtaining biopsies with endoscopy. Regarding the liver, graft versus host disease can be present there, but it is rare to have liver graft versus host disease without any involvement of the skin and or GI tract. Signs and symptoms include painful and enlarged liver, dark urine, pale stool, itchiness, and nausea. To diagnose liver graft versus host disease, we look at different tests that indicate injury to the liver cells and bile ducts. Liver biopsies sometimes performed to confirm the diagnosis and to make sure there's no other type of liver disease going on. However, a liver biopsy may not be performed if there's concern for risk of bleeding, such as if the patient has low platelet counts. So how is it treated? So typically, graft versus host disease is treated with medications to suppress the immune system, specifically steroids such as methylprednisolone and budesonide. If patients have chronic graft versus host disease and associated esophageal strictures, then dilation by endoscopy can be helpful. Some patients who have a poor functioning pancreas may require pancreatic enzyme supplementation, and that would help them digest fat. Anti-diarrhea medications can be prescribed, such as loperamide and tincture of opium. And those patients who are unable to eat well due to nausea, vomiting, or pain, or if they have frequent diarrhea, they may require supplementation with enteral feeds and or TPN. I will next talk about GI cancers in Fanconi anemia patients. They occur less frequently than head and neck cancers, and they can present in the esophagus, liver, stomach, and colon. Of note, there's only been one case of colon cancer in a patient with Fanconi anemia that has been reported this far. Esophageal cancer has been reported in patients starting at age 20. And liver tumors have been reported in teenage patients, but this may have been related to the use of androgens, like I discussed before. Regarding esophageal cancer, there are no clear guidelines for surveillance in Fanconi anemia patients. Some providers consider performing an upper endoscopy every year. However, it is also questionable at what age do we even start performing these procedures. In general, it is important to consider the risks of sedation or anesthesia and the risk of the procedures themselves when trying to decide if and how to screen Fanconi anemia patients for esophageal cancer, especially with the limited data that we have. Upper endoscopy, however, should be performed in patients that have symptoms such as difficulty swallowing, pain with swallowing, or persistent abdominal pain that has not been found to have a cause identified. For other cancers, so there are no current recommendations for early colonic cancer screening, especially since there is no evidence at this time that Fanconi anemia patients have a higher risk for developing colon cancer at an early age. Regarding liver cancer, some experts recommend a yearly ultrasound of the liver, particularly when receiving androgen therapy. Otherwise, patients can also get labs drawn each year looking for any signs of liver injury. So this is a summary slide of some basic points that I want you to take home with respect to FA patients and GI-related issues. So first off, Fanconi anemia patients can be born with GI tract structural or anatomical abnormalities. Patients are at risk for nutritional issues, whether it is poor weight gain or obesity. There are potential GI and liver complications that can develop as a result of certain medications and therapies for Fanconi anemia, such as androgen therapy, stem cell transplant, use of antibiotics, previous surgeries. When it comes to GI cancer surveillance, unfortunately, there is currently a lack of formal guidelines, and more research on this topic is required. But overall, a multidisciplinary approach, including GI and nutrition, is important to optimize the benefits of therapy and lead to improved outcomes in our Fanconi anemia patients. Thank you, everyone.
Okay, thank you very much for the presentation. We do have a couple of questions to start off with, and we have a hand raised by Beth who would like to ask a question.
Sure.
Beth, if you're there, let's see if we can get you unmuted. Okay, I think we'll maybe come back to Beth and see.
She might be able to unmute herself. I'm not sure, but she could try.
Thank you, Jordan. I'll give her a few seconds.
Beth's hand's been up for a little while, so maybe check on with, looks like Melissa.
Okay, so Melissa, if you would like to ask your question, you can go ahead.
Hello?
Hi, we can hear you.
Okay,
You can go ahead and ask
hi.
your question.
My son had the adrenal atresia surgery at 2 days old, and he wasn't diagnosed with Fanconi since till he was 2 years old. And I was curious to see if it would return or he might have same intestinal issues. He had an intestinal issue and the stomach issue. I was just wondering if it would be a chance for it to return or something I should be looking out for to see if he still could have that certain blockage.
Yeah. So some patients, and I'm assuming he's never required an endoscopy since the repair?
No.
Okay, great.
Else.
That's great. That's great. So some patients, depending on the surgery and any complications after, some patients develop some scarring in that area and they do stricture, but some patients don't. So it's not like that we should expect that to happen. But things that you would look out for are, recurrent vomiting, seeing green in the vomit if the patient is vomiting, persistent nausea or vomiting or pain. And really just seeing if they're not able to keep things down. So if he otherwise is doing okay, there's no reason to necessarily do imaging or do a procedure just to look. It's really just going by, if he's otherwise, maintaining his weight and doing well without any symptoms, then it's just something that you would watch.
Okay, so he can still have a recurring issue, even though it's been like 6 years. He can have a recurring
No,
issue
I
at any
think
time.
at this point it's less likely. I mean, you could always having a prior GI surgery in the past can put you at risk for adhesions in the bowel or outside the bowel rather. So these patients always are at risk for some sort of developing obstruction in the future. Not to say that they're going to have it, but again, it's hard to predict, but there is a risk, but I wouldn't say if he's doing well right now, then it's not something that I would be concerned about.
Okay, thank you.
Of course.
Okay, thank you. And we have another hand raised by Alyssa who would like to ask a question. Alyssa? Alyssa, if you can hear me, you're able to ask your question, I think.
Hello. Hello.
Hi.
Hello, can you hear me?
Yes, hi, Alyssa.
Hi, actually, this is Pat, Alyssa's mother. I was thinking my daughter was going to ask a question. I'm in a different location. But my question was about the SIBO or the SIBO, the small intestinal overgrowth, bacterial overgrowth.
Okay.
I just recently did the breath test for it myself, and my daughter has the same symptoms. And I did some research on it and also talked to the chiropractor that got me the test, because you cannot get the test, at least here, through a traditional medical doctor. And I found that there are herbs that treat SIBO better than the antibiotics. And there's even a site from NIH online that says that their tests show that the herbs are better than the antibiotic for treating it. Do you know anything about that?
I have not heard about that, at least in children. This is not something that we do, since we typically would feel more comfortable if there were studies done in children. So no, that's not something that we often perform.
Okay, because my daughter is an adult. She's 43, and I'm 69, and all the symptoms for both of us, we are helped by the FODMAP diet.
Yeah.
But I'm continued to have serious problems, and I think she might be too.
I see.
So, so it's for adults for us.
Okay. I mean, I know in general for the adults, the standard of practice still currently is doing antibiotics first and then making some changes to diet if necessary. I think probably more research is necessary for us to start recommending that. But I think it's something that you can ask and show the article as well. I'd have to see kind of the details of how the study was performed as well.
Okay. All right. Like I said, it was done by NIH though. So
sure.
Well, thank you very much.
Of course.
Okay.
Okay, thank you for the question. We have a question from Matt, who's 23 years old, post-BMT, and he'd like to know what's considered normal liver enzyme levels for FA patients.
So in general, we like basically normal levels based off of the reference range. So again, I'm not sure what lab you use, but transaminases in the 20s or so. I have to also see, in general, also with the treatments that you're on, that can also impact your liver enzymes. So it's hard for me to kind of just give a blanket statement, but we aim for all of our patients to just have within the normal reference range if possible.
Thank you.
Does that answer your question?
He'll get back on chat and let me know.
Okay.
So our next question is also regarding liver enzymes, and they've been elevated for many years now. He or she had a liver biopsy several years ago, which it showed nothing.
Okay.
And
so
I'm sorry, it skipped on me, so just trying to find it. But because of the chronic elevation, how often should he or she be following up with a doctor for more biopsies?
Well, I think checking the labs more frequently would be helpful. I'm not sure if this patient has seen a GI or liver doctor in the past, because sometimes we want to rule out other things that I'm not sure, again, what the workup has been done. But, you could have fat in the liver. Again, I need to know when the biopsy was done in relation to the liver labs and everything. But I would say in general, you could start off with every 3 months. and go from there and see if there is a worsening or improvement or whatnot, and then see then what diagnostic steps should be taken. I don't think there's a right answer for scheduled liver biopsies. Again, I think it's all depending on the trend that you see with the labs.
Thank you. The next question is, what factors can be used to distinguish between irritable bowel syndrome and GvHD of the gut?
So things that you would be, so red flags. So red flags meaning the patient is failure to thrive, is losing weight, not able to do their daily activities, I would say are big red flags. If you see blood in the stool, that would be the ones with red flags, and blood in the stool and more severe symptoms, I would point more towards GvHD. There are some lab tests that actually could be done as well to help differentiate. One test that I like to send is called the stool calprotectin. That's looking for inflammation in the colon, and usually, to help differentiate irritable bowel from another underlying disease process. If you have inflammation in the colon from a high fecal calprotectin, that can help you kind of say, okay, this is less likely irritable bowel, since you shouldn't have a very high abnormal stool test for that.
Okay, we had a follow-up question from Matt about the liver enzymes that was
Yeah.
asked earlier, and he's asking if they're elevated, which is the best course or procedure to suggest? Would you do an ultrasound, a CT, or blood tests?
I would start with the ultrasound if that hasn't been done already, and then additional lab tests. Again, I'd have to see if there has been a previous workup before. I think looking also at the medications that you've been on, it would be helpful, and just kind of the overall trend.
Thank you, and thank you, Matt, for following that up. So we have a question regarding a mom whose daughter is 66 years old and she has major GI issues. She still wears a pull-up because she has GI problems. They've had to give her lactulose since birth and now have moved to Miralax. She sometimes does not feel the need to go, but will be going, so she wears the pull-up. Because of accidents. This causes problems because she has severe kidney reflux. So they get kidney infections quite often that grow out E. coli. So can you give any suggestions for this issue?
Yes. So in patients where, are they calling this bad constipation? Is that I don't know if she's gonna, well, yeah. In general.
Questions. But
right?
Maybe she can get on. So this is a typed question.
Oh, I'm sorry. Okay.
That's okay.
Yeah. So in general, if a patient has long-standing issues with constipation and feeling the urge, we often will recommend doing a manometry study, meaning that we use catheters to kind of see how well the bowel is moving, because if there is an underlying motility issue or issue with the movement of the bowel, then we can identify that and help treat that accordingly. So I mean, I'm not sure what she has, what workup she's done so far, but that's something to consider if she's been having long-standing issues with constipation.
Okay, great, thank you.
Yeah.
The next question is that my son had a bad fungal infection in his esophagus and they cleared it up, then said to take omeprazole daily. Are there any concerns about taking it over many years or things to be aware of?
Yeah, so like I mentioned previously, so if you have lower acids in the stomach, that can put you at risk for certain infections such as C. diff. So C. diff colitis is something that can happen. Taking acid blockers for the long term can also have impair certain vitamin absorption, and you can have issues with bone disease. These are all things that we kind of monitor for the long term. If we think that it's important to stay on the acid blocker, then we would kind of weigh the risk and benefits. Some patients, you could have a risk for kidney issues, but again, not everyone has these issues when staying on an acid blocker for the long term.
Okay, thank you. And what medications can you recommend to increase appetite?
So there's ciprofloxacin, or also known as periactin. That's one medication. Another one that some oncologists like to use are Megace. There's also dronabinol, which is sometimes prescribed, but usually I start off with ciprofloxacin.
Okay. And can you explain how ursodiol protects the liver?
Yes, so basically ursodiol helps promote the flow of bile through the liver. So if we're concerned that there's any stasis or there's issues with the bile flowing, that if it stays in the liver, it can irritate the liver. So that's why sometimes patients will be on ursodiol when they have high liver tests to help promote the bile, help it keep moving, and so that it doesn't further irritate it.
Okay, and we have someone expressing that they've had a poor appetite for the past 2 years and problems with nausea after eating. They eat 1 meal a day and that's all they can manage, but their weight is stable. After a big meal, he or she's blood pressure lowers and they feel quite faint. Is there a reason why this happens and anything that could be done?
Yeah. So I definitely think this person should see their physician regarding the feeling faint afterwards. Sometimes patients can have what we call dumping syndrome, where when they have a meal, it quickly goes into the GI tract, and it's a big load, and they could have their glucose, their insulin levels drop. It's something that this patient should be seen for. In terms of also the feeling full easily, I mean, this could be slow emptying of the stomach as well, conversely. So this patient should definitely be seen.
Okay. And our last question for now, unless some come up, is that somebody that's 20 years post-transplant, can they still have GvHD? I'm guessing of the gut is what they're asking.
Yeah. So GvHD, so especially chronic GvHD, can happen at any time. If you have had graft versus host disease in the past, you're always at risk for developing again. The bone marrow transplant team can answer this question better than I can, but theoretically, there is a possibility that you can develop graft versus host disease again. I think less likely since you've been out for so long, which is great, but it's something that we would consider if you develop symptoms.
Okay. And we do have another question. So what are some important tips on protecting the esophagus/GI tract from cancer when you've had TEF and are on meds?
Yeah, so again, there's not anything that we know right now that in terms of medications that are helpful for general protection of cancer. In patients with a previous history of TEF, again, like I mentioned during the talk, they are at risk for reflux disease. And with the constant irritation of the esophagus, you can develop what we call Barrett's esophagus, or changes in the mucosa of the esophagus. So being on an acid blocker could then be helpful in that case.
Okay. We have another question about the ursodiol. What's an alternative? There's a comment about storage of this drug. I'm not quite sure the context of that.
Unfortunately, there's no other medication that we prescribe besides ursodiol for bile flow. I know for certain suspensions, they need to be used within a certain period of time. I'm not sure what they were referring to in the question.
There's a shortage of the drug where they are. I'm thinking maybe Bone International.
Okay, yeah. Unfortunately, that's what we typically use. I haven't used any other alternative.
Okay, and somebody's asking about their daughter who's underweight, but when she eats certain foods, she says digested, I'm not sure, and cannot tolerate them, maybe nauseated and can't tolerate them.
Okay.
Should she have some kind of test? She has never had a stomach test.
Okay. I think first seeing the GI doctor would be helpful, because then the GI doctor can get more information and try to better characterize what's going on, because then that would help guide, what test would be next, like if the patient needs a gastric emptying scan or needs to trial another medication, that would be helpful. So I think that person should see a GI doctor first before requesting any specific tests.
Okay, thank you. And a question about oral aversion. Are they common with FA? They have an almost 3-year-old daughter who is only G-tube fed because of oral aversion. Her GI, a swallow study. Her GI did a swallow study, but it hasn't worked her up for anything and is putting her on Nexium.
Okay. Yeah, I mean, I wouldn't necessarily say that oral aversion is common, but with the several treatments that some patients go through, you know, also in preparation for a transplant or what have you, they can develop irritation in the esophagus and then develop an oral aversion to swallowing because they're associated with pain. So we are actually here at MSK, we're also developing a swallowing clinic to get, you know, GI nutrition and the speech therapist who is our swallowing specialist involved, so that all aspects are addressed. But yeah, I wouldn't say necessarily it's common, but it can happen, especially with all of the treatments that go on.
Okay, thank you.